Welcome to CME number 905.
Good evening everyone. I take immense pleasure in introducing the very esteemed guest we have tonight, Dr. Neeraj Saraf, who's MD in Internal Medicine, DNB Gastroenterology, Fellow of Advanced Clinical Hepatology, Mount Sinai Hospital, New York, USA. And he's a UNOS Certified Liver Transplant Physician. Presently, he is the Senior Director, Clinical Hepatology, Medical Director, Liver Transplantation of Institute of Digestive and Hepatobiliary Sciences and Institute of Liver Transplantation, Regenerative Medicine, Vedanta, the Medicity Guru. Sir has extensive experience and is a very renowned name in the field of liver transplant hepatology. And I'm sure we'll have an insightful talk today by a very esteemed guest. So he'll be speaking on life after liver transplantation. Neeraj sir, over to you.
Good evening everyone, and thank you for being here, and thank you the organizers for such a warm welcome. In the next few minutes I'll be talking of life after liver transplantation. So the sequence was planned to be the reverse. Dr. Soin, who is just on his way, is going to speak on liver. He's actually here. So, but anyway. So, he will be speaking on obviously the procedure and the indications and more details about liver transplant. So, I will start on life after liver transplant and take you through some of the things which I think there are a lot of myths amongst people about the procedure, about what the quality of life is after transplant, about what the quantity of life is. So I'll talk a little bit about the quality and quantity of life after transplant. You know, I still get patients who say that, you know, we've heard that you have to be isolated for the rest of your life and that your liver will only work for a few years. So there are a lot of myths amongst patients, amongst doctors as well. So what are the do's, don'ts? When can a patient work? When can he travel? When can a female recipient get pregnant? When can they be actively involved in physical activities, sports, sexual life? So these are quality of life issues which a lot of people have questions, and I think they're very important to address. And then I'll talk a little bit about the medical part, monitoring patients after liver transplant. How do you monitor them? When do you do their labs? What is it to live with immunosuppression? I think that also is a very overhyped thing, that immunosuppression, again, like you have to be isolated and you have to lead a very limited life. That is all not true. So we'll talk a little bit about complications of immunosuppression, what are the costs involved, and some of the common problems we face after liver transplant, like metabolic syndrome, people going back to alcohol, cancers recurring again. So this is not a talk on complications after liver transplant. There are many complications also, but I'm not going to talk about them. I'm more talking about what a patient after transplant has in a long-term manner in terms of quality, quantity, and more of long-term problems here rather than short-term complications. So one myth is the success rate. The success is now, we've been doing transplants for more than 20 years now in this country, and Dr. Soin will talk about that on transplant at our hospital and transplant in India. So one myth is that it is not a successful procedure. Well, it is. The short-term survival is at about 95 to 96%. I've given a more modest figure of more than 90% here. Another myth is that elderly people cannot undergo a transplant. Well, we have done, I think, at least 100 patients who are 70 or more, and we have done one patient who was 78 This was 20 or maybe I think 15 years ago. So he's in his early 90s now. And the maximum age we've transplanted is a few years ago, a patient from Cambodia who was 80 years old and is doing well. So age is not a barrier, it is the physiological age which matters. And if a person is fit at the age of 75, 78, he can undergo a transplant. Quality of life, again, like I said, there's a lot of myths involving that there's a lot of infection and you need to, sort of stay away from people. That is all not true. I'll talk a little bit about costs after transplant. And another very important question which patients have is that will I be on a limited diet? Because a person with liver disease has so many diet restrictions that it's very important for him to know whether he can eat normally after a liver transplantation. And the answer is yes, they can eat normally. Of course, they have to eat healthy, but they can eat normally. So in terms of do's and don'ts, I think the only do is to lead a healthy lifestyle, I think, which is not true for only a liver transplant recipient, it's true for any patient and any human being and any doctor as well, for all of us as well. So diet and exercise is the only thing we really advise. Of course, hygienic conditions are important. Alcohol is an absolute no, especially for people who underwent transplant for alcohol-related liver disease. And there are some drugs which you have to take, and I'll talk of that, and some vaccines which post-transplant patient should take. So these are some of the very broad do's and don'ts which a patient must follow after transplant. Now, what are the timelines of returning back to normal life? So, light exercises you can actually start straight away after surgery. Walk a little bit every day, and as you recover, you can go longer. Moderate exercises, for example, brisk walking or even light jogging you can do as early as 2 months after a liver transplant. And at 3 months, we tell our patients to resume complete activity, go back to work. They can drive, they can travel, and they can go on a holiday in the first, after 3 months anytime, and return to full active work. So even people start working part-time or people start working from home as early as 6 weeks. But I'm talking of going back to full active work in full physical setup and go on a holiday as soon as 3 months after a liver transplantation. So coming again to quality of life, now this is a gentleman, I think he was transplanted more than 10 years ago, and he actually, this is a couple of years ago, there is something called the World Transplant Games, in which people who have had a transplant, kidney, liver, bone marrow, they all participate, and this gentleman participated in the World Transplant Games and won a medal also. So this is just to highlight that the quality of life, the physical strength, everything becomes absolutely normal to the extent that you can even qualify or take part in active sports. Now, common questions about life after transplant. Can I drink alcohol after liver transplant? Like I said, if it was because of alcoholic liver disease, then it's an absolute no. We generally say no to everyone, but if you had a transplant for, let's say, hepatitis B related disease, and you have been a social drinker and can limit to that, then maybe, once in a while a drink can be allowed. When can I have sex after liver transplant? Well, as soon as the wound is healed and you're physically and mentally ready, that's absolute yes. When can I have a baby after liver transplant? So many women have successful pregnancies after liver transplant, and we generally advise that 1 year after surgery, a female recipient can become pregnant and can conceive and undergo pregnancy. So women with decompensated liver disease are often, as you would know, are amenorrheic, and pregnancies are very rare. So once they have a new liver, the hormones and the physiology, everything changes, and the females are fit to undergo pregnancy as soon as 1 year after liver transplantation. And there are certain drugs which we need to monitor, So tacrolimus is the drug of choice, and I'll talk about that a little later as well. So you need to alter the immunosuppression a little bit, but a female recipient can undergo pregnancy and deliver a healthy child, and we've had many such females. This is, with permission, a young lady who I think had ACLF, acute on chronic liver failure, transplanted in 2010. At that time she was unmarried, she got married, and now she has a healthy child. Again, talking about quality of life, this is a patient who underwent liver transplant for acute liver failure, and after 14 years she is herself a doctor now. So again telling us that we can actually, patients can lead an absolutely normal life. In terms of longevity, I think this is one of our patients who was transplanted about 15 years ago at the age of 70 and is 85 plus and leading a very healthy life. So these are just a few examples to tell you that people lead a normal healthy life after liver transplant. They can go back to active sports, they can have children, and age is not really a bar. Coming back to a little more medical protocols after transplant. So this is how we monitor a patient after transplant. So for the first 3 months they have weekly blood tests. After 3 months it's about once in 2 weeks. After 6 months it's about once a month. And after 1 to 2 years, blood tests are just one every 3 months. So again, this is a myth that you need very frequent testing. So after 1 year, you just need 3 monthly blood tests. Of course, once a year we like to do echoes in these patients, a DEXA scan, maybe an X-ray, and if they had a transplant for a liver cancer, then we'd like to do a CT scan every 6 months for the first 2 years. So monitoring is not really that extensive, and a year after transplant, you actually really don't need a lot of monitoring. Now coming to the important question of immunosuppression. So these are the drugs which we commonly use. The calcineurin inhibitors are the mainstay of immunosuppression, which include tacrolimus and cyclosporin. Then there are others like mycophenolate, everolimus, and of course all patients get corticosteroids for the first few months. Now, one common question amongst physicians, gastroenterologists referring patients to us, and the patients are, what are the adverse effects of immunosuppression? Are the adverse effects serious? Are they bad? How expensive it is? And another question is, can immunosuppression be stopped? And the answer to that, I'll first reply, is probably not. So the amount of immunosuppression keeps decreasing, and maybe 5 years down, patients are on extremely small doses of immunosuppression, but our experience is that you can't really stop it. Maybe you can even give it twice a week or thrice a week a small dose, but once you completely stop, then people do have rejections. So these are the major side effects of immunosuppression of various categories of drugs. So corticosteroids, we all know, we do as physicians give it for various indications. So obviously, there is a little bit of higher infection, hypertension, glucose intolerance, Cushing-Point facies, but the kind of dose we use and we taper it off within the first 3 months, hardly any patients get any side effects of corticosteroids. The most important group of drugs which we use is calcineurin inhibitors, and the most common drug we use is tacrolimus. And renal impairment is one side effect. Hypertension and glucose intolerance are again side effects of CMI inhibitors. But I must tell you that, if you look at old studies, they say that 20% of patients on tacrolimus will need a kidney transplant in 15 years. We have done 4,500 transplants. We have follow-up of 20 years now. I think, Dr. Soin, we probably have 3 or 4 patients who have undergone a kidney transplant, I think, after liver. So these are all overstated statements, because earlier era, very high immunosuppression was used. And now we have learned that you can use very small dose. So patients hardly have any side effects with these immunosuppressive drugs. Now again, when we talk of immunosuppression, cost. So let me tell you, the cost of maintaining a cirrhotic patient is much higher than maintaining a patient after liver transplant. We all know cirrhotic patients, one admission in a private sector hospital, a few lakh rupees. Ascites, tapping, bleed, ICU admissions, it's much more expensive. Immunosuppression, the first 3 months, the costs are maybe about 15,000 rupees a month. 3 to 12 months, they go down to less than 10,000 rupees a month. And after a year, they're probably about 5,000 rupees a month. So immunosuppression is really not expensive. We use, there are very good generic brands available. So 5 to 7,000 rupees a month after a year is really not a lot of expense for a liver transplant recipient. Mind you, one albumin costs 5 to 7,000 rupees, which we use left and right for chronic liver disease patients. So I'll talk a little bit about when we talk of complications. Obviously, life after transplant, obviously everything is not great. They do have some problems. So early on, you can have infections, and the first 6 months, these patients can undergo rejection. That happens in about 10 to 15% patients, but graft failure because of rejection is extremely rare. So unlike kidney, where rejection is more common and a lot of patients, 2-3 years down the line are back on dialysis, in liver, we hardly ever lose a graft because of rejection. Rejection is very easily treatable if you recognize it early. There are some long-term complications, and I think the biggest problem which all of us are facing, and I'm sure you see also in your practice, is metabolic syndrome. So diabetes, post-transplant diabetes, hypertension, obesity, cardiovascular issues, fatty liver, these are common problems which liver transplant recipients also have. De-low malignancy and recurrence of HCC is again something which are long-term problems which patients have after liver transplant. Disease recurrence, I'll talk of briefly. Patients with autoimmune liver disease can have disease recurrence, and renal complication is a potential side effect of immunosuppression. But like I said, it's not really a big problem in our country. So metabolic syndrome, as you know, India is the diabetes capital of the world, and there is a lot of metabolic syndrome pre-transplant. And if you look at this figure, post-transplant, everything becomes much higher, because of obesity, because of the drugs we use. So there's a significant increase in diabetes, hypertension, dyslipidemia after liver transplantation. And I think this is the biggest problem we face now after transplant, that patients develop metabolic syndrome and complications of metabolic syndrome. So this is our own paper which we published almost 10 years ago, showing that the BMI, hypertension, diabetes, LDL, triglycerides all increase significantly after liver transplantation. The management of these metabolic risk factors is very similar to what you do in your practice in a non-transplant patient. So they would be managed with diet, exercise, statins, and the usual anti-diabetic drugs. So there is really nothing special about managing metabolic syndrome after transplantation. If you look at literature, they say that the commonest cause of death after liver transplant is not liver related, actually, it's cardiovascular. So cardiovascular is something which we need to look out, again, because of diabetes, because of obesity, because of hypertension. And so we have, there are risk stratification algorithms made for these, where you do a very strict surveillance for the presence of proteinuria, hypertension, and of course we keep advising them on lifestyle changes. Smoking obviously is a big no, dietary choices, physical activities. Sometimes we alter immunosuppression if people have metabolic syndrome. And of course, I think again, treating the diabetes, treating the hypertension is what is important. So this is our protocol for managing metabolic syndrome after transplant. So there is high metabolic syndrome, high diabetes, high truncal obesity in our patients. So, and which leads to cardiovascular morbidity, and it leads to recurrence or de novo metabolic associated steatotic liver disease. That's the new name given to MASL now, which is the new name given to NASH or NAFLD, which we knew earlier. So we minimize the CNIs because they cause hypertension, diabetes. We withdraw steroids early, and MMF, mycophenolate, is a very safe drug, and we use that more liberally now in patients with metabolic syndrome. De novo malignancies are again something which patients can get after liver transplant. Skin cancers, they occur mostly in the Western world. In white skin people, we hardly ever see skin cancers. Solid organ malignancies are again not very common. What we see sometimes is post-transplant lymphoproliferative disorders. Again, I think the number is very small. So malignancy is not really a problem in our population. HCC recurrence does occur, and I think probably Dr. Soin might be covering this in his talk. So, how you select patients reflects how HCC recurs after transplant. So the size of the tumor, the number of the tumor, vascular invasion, these all lead to increase in HCC recurrence. And we have downstaging strategies. So we are probably one of the first centers to start transplanting patients with higher numbers, higher size, and even with vascular invasion. We have protocols for that, and we downstage them with radioembolization or SBRT, and we can successfully transplant these patients. And this is our own data of transplanting patients with portal vein tumor thrombus. So this, I think we published in 2020. So till 5-6 years ago, portal vein tumor thrombus across the world was considered a contraindication to transplant. We developed this protocol of downstaging them, getting, remove the tumor thrombus from the portal vein and transplanting them successfully. And we have a 5-year recurrence-free survival of about 55% in these patients. So obviously it's lower than the usual, and this has led to the change in practice in the entire world. So a lot of centers across the world now seeing our results are transplanting patients with portal vein tumor thrombus. Like I said, renal outcomes are important, and pre-existing CKD, diabetes, hypertension, these all play a role in recurrence of renal problems after transplant. Again, these are, like I said, old data showing that there is high renal problems, kidney transplant need after liver transplant, but we have again developed a protocol where we switch patients off tacrolimus to everolimus, which is a safer drug, at 6 months if they have eGFR of less than 60. So this is again something we started in this country of using everolimus in patients who have renal dysfunction, and we've got very good results now that you can use everolimus and hardly any patients develop renal toxicity after liver transplantation. Alcohol relapse, I think this is a problem, and across the world about 20% patients go back to drinking and spoil their liver alone. Our data is that I think we had about 6% recipients who underwent, who had significant recidivism. So I'm not talking about occasional drink, but recidivism to cause harm to the liver is only about 6% in our cities, which is pretty good, and I think it's because of the regular counseling we do, and I think probably because there is better family support in our country as compared to Western countries, so probably there is less going back to drinking. Like I said, we have developed protocols for preventing relapse after transplant, and we actively involve, so the hepatologists are involved, we have coordinators, and we actively involve the psychiatrists and the de-addiction doctors to counsel them for not going back to drinking. This is one of the big problems we face now, is recurrence or de novo fatty liver after transplant, and I told you the reason, because these patients gain weight, they start eating much more than they should, they develop diabetes, they develop hypertension. So again, this is our own data showing that about 1/3 of the patients develop significant fatty liver after liver transplant, and we did liver biopsies in these, and the fatty liver progresses to fibrosis much faster in a liver transplant recipient than in a naive patient. So I think this is something which is going to be an epidemic now, and a lot of transplant patients, we have to really counsel them hard to not increase their weight. Hepatitis C and hepatitis B are actually really a breeze now. Hepatitis C, you all know, DAs are there, so we can effectively treat these patients even if they have a recurrence after transplant. Hepatitis B, we have excellent drugs, tenofovir, entecavir, so recipients need to take these drugs lifelong, but B and C are never a problem now after transplant. So no patient has graft loss because of recurrence of hepatitis B or C. So I've talked of the recipient. I think again Dr. Soin will probably cover this. I'll just speak a few words on life after donation. So you must know that most of the transplant in India and 95% of the transplant in North India is living donor liver transplant. So a family member gives part of their liver to the recipient, and now we have Dr. Soin has pioneered our program, and we are the leading center for doing robotic surgeries, and I'm not a surgeon, so I'll leave this topic to him. And there are a lot of donor benefits, and just to tell you that donors lead an absolutely normal life. They don't need any medicines. The hospital stay of a donor is about 6 to 7 days, and in 1 month they are back to full productive life. And after that they can and this is a donor who lifts weight, and so you can absolutely lead a normal life after liver transplantation, after being a donor. So again, this is just our journey. More than 4,000 transplants now, about 97% short-term survival. We do about 20 to 25 transplants a month, and our survival, this is our survival, 1 year 93%, 3 years 85%, 10 years 76% survival, which is probably better or comparable to anywhere in the world. This is our pediatric survival, which is even a little better than adult, and this is part of our team. A lot of the team wasn't there for this picture because they were working or they were in the OTs, but this is part of the team which includes the surgeons, the liver physicians, the anesthetists, the critical care, pathologists, radiologists, and so on. So liver transplant is really a teamwork, and we are blessed to have a very strong and dedicated team at our hospital. So my take-home message for today evening is liver transplant is standard of care and curative treatment for all forms of liver disease, end-stage liver disease, acute liver failure, liver cancer. More than 15,000 liver transplants have been done in India now with high success rate. Out of these, I think probably 1/3 are done alone at our center. There are many myths which I talked of surrounding liver transplant amongst people, general public, and amongst doctors. And I think we need to educate ourselves and educate patients more on these. Life after transplant is normal, it's productive, and they have good longevity. Costs after transplant are not prohibitive, and they're, like I said, they're much less than living with liver cirrhosis. Living with immunosuppression is not as complicated as we think, and people can lead a good, healthy lifestyle. Metabolic syndrome, I think, is something which is going to be an epidemic. It already is epidemic, and we must address and be careful about. Disease recurrence is a concern, but can be reduced with leading a good lifestyle and counseling for not taking, not gaining weight and not drinking. And living donation is safe. Donors have a good quality of life. However, I would also say that I think the need of the hour is to promote more cadaver donation so that we can actually, people, living donors don't really have to donate. Thank you.
Sir, stage, and I would request Dr. S.K. Mathur to please come and felicitate the very world-renowned and legendary liver transplant surgeon, Dr. A S Soin. Dr. S.K. Mathur is the patron of Physicians Forum of India.
Pleasure to be here.
Sir,
सर
एक कम बोलिए।
फुल्ली बीच में से लाइट राइट सर आप भी आपको लाइट में से सर लेकिन
We would like you to open, we'll serve the cup. So we would like you to open the cup and read the message of.
ये इसके अंदर से ये निकलेगा सर है ना कुछ कुछ निकलेगा जरूर सर
We would like to read this.
So the Physicians Forum of India has a motto: empowering doctors for a healthy India. So empowering doctors for a healthy India. And of course, I and my team, we fully support this.
थैंक यू सर
I am a gastroenterologist and I've been following you since years. I think you were at Gangaram at one time and
Yes.
I came with a few patients when I was very young, I guess. And now I've referred some patients to you and I think I'm going to personally refer them in the future. So over to Chauhan sir.
Sir, Dr. Shubham is Director of Gastroenterology at Organ Matham. Alright, we are very feel proud and privileged and honored for your presence here in Physicians Forum of India. We are an academic forum involved in academics for the last 19 years. Today happens to be the 905th 905th CME, continuous uninterrupted. For the last 19 years, not a single pregnancy has been lost, unless it was a Diwali or a Holi.
दैट मींस
Sir, how does it feel like to be a legend? A few words.
You know, I never thought of it like this before or now. I'm a surgeon like many of you surgeons. And what we try and do is, I think when we all become doctors or want to be, when we all become doctors or want to be doctors, you know, start out in a career, I think it's a calling. You just want to help patients, you just want to make them smile again, you want people who are unwell to become well again. That is the core, actually. So nobody, I don't think any doctor thinks of themselves as a legend or, you know, whatever, champion or rich or anything like that. I don't think that thought comes to most doctors. And certainly doesn't come to my mind. But I feel privileged to be among friends like you, and I feel privileged that I'm a believer, so that God has chosen me and my team to deliver happiness and health to people who are suffering. That's the reality.
I would request Dr. Shubham, our moderator, to introduce Dr. A S Soin and to take the CME forward.
So Dr. A S Soin needs no introduction. To be very honest to anyone, he's a legend of the field of liver transplant. And majority of the teams in India today have been trained by Sir. And he's been transplanting around 25-30 per month, and the number has gone above 4,000 now with a success rate of more than 95%. So I guess all of us are privileged to meet Sir. I met you as a patient earlier because you transplanted one of my relatives way back. And now sending you patients, and next time I can tell them that I know them is a different testament and credibility to my career. And I think I am very happy to stand here today, and I'm really obliged, sir. And the stage is yours, sir. We'll be very happy to hear you. Thank you, sir.
Good evening all, and first and foremost I have to say what a pleasure it is to be with all of you, the academic friends and colleagues from the Physicians Forum of India. So today's theme and topic is liver transplantation, and you heard Dr. Neeraj Saraf, who's amongst the most eminent hepatologists this country has, who's been practicing transplant hepatology for, like I said, 20 years. Give you a perspective of what happens after liver transplantation. So let me now take you through the journey of liver transplantation over the last 26 years. Why 26 years? Because liver transplant in India started 26 years ago. I was at Ames for about 11 years, from 81 until 92, and Professor Nandi was the GI surgeon, the country's first GI surgeon, or amongst the top 2 GI surgeons who started GI surgery, and I was his student. And I think in 1990, I saw a case of hepatectomy. I assisted a hepatectomy in the OR, and I think he bled so much, we transfused him about 50 units of blood. And he had a right lobe tumor. Eventually he went home, and he was well until I left Ames for about a year and a half, and hopefully did well after that. But I understood that it had nothing to do with Dr. Nandi. It's just that the technique of liver surgery was in its infancy in India at that point in time. And I was very interested in GI surgery, and the Department of GI Surgery at Cmes had leanings towards liver transplantation right from the beginning. So I had this thing in my mind that I have to learn liver surgery properly and perhaps liver transplantation. So I went to UK and I trained at Cambridge University, and I was there for about 6 odd years. 1997, I had finished my training. I had done all the 3 RCSs and everything. I was a registered specialist, and I was appointed lecturer at Cambridge University in the Department of Surgery under the Division of Liver Transplantation. My wife and I had a small baby. We were living happily in our own house in Cambridge. And then suddenly Dr. Pratap Reddy came to UK, and he was looking for doctors to populate his new hospital in Delhi. At that time, we had just started in 1996, the Delhi University Hospital had started, and he came to UK and he invited about 30 of us working in different parts of UK to meet him and his team. And we met in London, and there were 5 of them sitting at the dais, and there were 30 of us young doctors across the room. And each of us had to get up and give a 2-minute introduction of what we were doing and what we were up to and what our plans were. And then after that brief public introduction or interview, 5 of us were called inside. Like we made it to the second round of interview. So I was one of those 5. And then he told me that, Dr. Soin, I know that you're doing good work at Cambridge and you've just been appointed faculty. But you know what? I have made the best hospital in India, tertiary care hospital. Why don't you come and start liver transplant in India, because it doesn't exist there, right? And honestly, I was at Ames, and after that I was at Cambridge. I had no clue about private practice or private hospitals. But this guy looked very impressive, and I think even at that point I understood he was quite a visionary. And I went home and told my wife that, look, I met this guy and he's offered me a job in India. What do you think? And she was in the middle of doing her PhD, also at Cambridge. But we were both very India-philic people. We used to visit India 3-4 times a year, call home every day. So we decided we'll return. And then we came back. And I left my job at Cambridge and I came back in 98. My wife left her PhD, but she finished an MPhil. If we had stayed on, she would have finished her PhD. Anyway, so we came back, and in 1998, March, I think I joined Apollo Hospital, and 8 months later, there was a donor, a deceased donor, like a brain dead person in the ICU, whose family was very keen for donation. I don't know where they heard about donation, because it didn't really exist in India at that time. Anyway, we counseled the patient's family, the brain dead person's family, for donation. They agreed to donate, and we did our first transplant. First transplant was a deceased donor transplant on a 43-year-old male who was having cirrhosis because of alcoholic addiction. He had ascites, jaundice, and he had all the features of chronic liver disease. And the deceased donor was a 55-year-old female. Anyway, we did our first transplant on the 5th November night, finished on 6th morning, and then we discharged him 13 days later. So he was India's first successful liver transplant. and then he lived for 9 years without any trouble. Then he started drinking again. So 3 years later, that's 12 years from his transplant, he was dead. 10 days later, on the 15th of November 1998, we transplanted a 20-month-old baby. His father donated the left side of his liver, and that was the country's first successful pediatric liver transplant, and also the first successful living donor. And of course, now he's a doctor. He's 28 years old, and he works in Bangalore. He actually DM'd me on Twitter a year and a half ago asking for a job in liver transplantation. He says, I want to work in pediatric liver transplantation, but his parents said that, they're in the south, so they said, no, you work in Bangalore. So anyway, he's working in Bangalore now. So after that, we've now been through about 4,500 plus liver transplants. And like you said already, we do about 30 transplants a month at Moderator. This is a whole string of firsts. Because we were lucky to do the first few cases, we really were the first to do most of the milestones in liver transplantation in India, if you start at the bottom. And we now have the country's largest series of liver transplants of 4,500 plus. And we're also the country's largest and the world's second largest adult-to-adult robotic donor surgery program, which means that we have done the maximum number of adult-to-adult robotic donor surgeries in India, and second after the group in Riyadh. More about that later. So, actually living donor liver transplant is the reason why liver transplantation is successful in India, because we don't get that many cadaver donors. And if you remember Neeraj's parting thought, a statement, he said that it would be nice to have deceased donor donation so that living donors don't have to donate. But unfortunately, even today, 85 to 90% of liver transplants in India are living donor transplants. I mean, fortunately for the guys who are otherwise dying, they get saved, but healthy people have to undergo surgery. Anyway, so what sort of a donor can donate for liver transplantation? It has to be an 18 to 55-year-old person whose blood group compatible, BMI should be less than 33, ideally less than 28. Only family donors are allowed, and each donor and recipient is actually approved by a government authorization committee. So a lot of people think that there are rackets and stuff, but it doesn't happen. There is no unrelated donation or paid donation happening in liver transplantation in India. These donors have to be viral serology negative. They have a CT scan of the abdomen and an MRI to look at the CT, liver anatomy, the vascular anatomy, the biliary anatomy. And mainly, what we do is now we do virtual surgery on the CT console. We actually draw a plane where we're going to eventually surgically divide the liver into the right and the left halves, and what's going to remain in the donor and what's going to go to the patient. So we do that kind of virtual surgery, and we determine the volume that's going, what vascular structures are going with the graft to the patient. So we know exactly beforehand how much the donor is going to retain and what the patient is going to get. Fatty liver is very common, so it's common among donors also. We accept up to 20% fat in the liver for right lobe donation, which is the bigger of the two lobes. And we accept 30% fat for left lobe donation, which is the smaller of the two lobes. And in terms of recipients, they are several categories. They're chronic liver disease, acute and chronic liver failure, and acute liver failure. And then largely, some of them get transplanted largely for cancer. So, among the chronic liver disease patients, the typical scores that you look at are MEL scores and CTP scores, and anybody 8 and above CTP score or 15 and above MEL score is really a candidate for liver transplant. And apart from that, you can have things like refractory ascites, hydrothorax, refractory portal hypertensive hemorrhage, spontaneous bacterial peritonitis, recurrent hepatic encephalopathy, even if they don't make this course, but if they have all this, then they need a transplant. And then other indications here. Now, I will take you through, because I'm a surgeon and I did say cutting edge in liver transplant surgery as the topic of my talk. I will take you through stuff that we have introduced, innovations that we have actually introduced over the years, which have become adopted throughout the world, and we published all this. We've been very, very prolific in publication. So, one of them is, and I'll keep it sort of tempered down because I know that majority of you are not surgeons, is that when you divide the liver into the right and the left sides, there are three outflow veins: right vein, middle vein, left vein. Right vein drains the right side, left vein drains the left side. The middle vein actually drains both sides. So there's always been this controversy that should you retain the middle vein with the donor or should you take it with the right lobe for the patient? And we devised some techniques about 15 years ago, which we published, by which you retain the middle vein for the donor safety with the donor and you make a new MHV for the recipient. So we've had 5 or 6 publications on that. Then biliary complications are an Achilles heel of living donor liver transplantation. Between 8% and 25% of these patients after transplant will have biliary complications. Our biliary complication rates are in the region of 11 to 12%, which are on the low side. And we described a special technique to reduce biliary complications, again about 15 years ago. And majority of the living donor centers in the world have adopted this technique. Now, what about donor practices? This is a seminal paper which we wrote a while ago, and this was 5-6 years ago. This was based on a worldwide survey of donors. So this gives a policy for selection of donors. I'm just showing you our work, which has been innovative and got adopted throughout the world. I'm not going to take you through the techniques of liver transplantation. We've also shown for the first time that it is safe to use right lobe grafts with up to 20% microvesicular steatosis without compromising donor safety and recipient outcome. And this shows the survival of patients who received non-fatty grafts versus those who received up to 20% fatty grafts. And they did equally well, the recipients, and donors also did well. There is, now this number is much larger. About 10 years ago we published the fact that donors or prospective donors in the family who have fatty liver can actually undergo strict diet and a regulated exercise program, after which their fat in the liver can come down and they can donate. So we had shown this for the first time that fat reversal in donors is possible. And of course now this number was only 15, 16, but it's in the hundreds now. We also showed for the first time that it is possible to put in smaller grafts than usual into recipients and yet have good results. Now what do I mean by that? Normally, a living donor transplant needs 0.8% of the recipient's body weight. That's the amount of liver that's needed by a recipient. So if I'm a 80 kilo recipient, then I will need 640 grams or 650 grams of liver, 0.8%. But sometimes with portal inflow modulation techniques, it's possible to transplant smaller volumes with equal success. This is what basically this is about. Again, this is the most often quoted paper in the world literature on this topic of putting in small livers into recipients. He showed that small livers do equally well as normal sized livers, provided they have portal inflow modulation. Now, transplantation for HCC. Now, this is quite a controversial thing. Majority of you understand that patients who have hepatocellular cancer restricted to the liver, not spread outside of the liver, not spread into the blood vessels of the liver, these patients can be considered for transplant. But initially there used to be size and number criteria, like you can't have a size bigger than 6.5 centimeter, you can't have more than 3 cancers. But we broke this dogma, and we accepted patients with any size, any number, all comers. Of course, as long as they didn't have metastasis. And we were the first ones to show that you can actually extend these criteria for HCC and save more lives. And now this size number thing has kind of gone out of the window, and now tumor biology is very important. So tumor biology is spelled out by tumor markers and genetic and molecular markers and response to localized therapy and lots of other parameters. But what I'm saying is tumor biology is much more important than size and number. We had shown this for the first time, and this is a paper that depicts that. Liver transplantation in the world's top liver transplant journal. Then we've also introduced a new protocol for transplanting patients who have cancer in the liver that has gone into the portal vein. So if they have vascular thrombosis, tumor thrombosis, a select group of these patients, possibly about 40%, can undergo liver transplantation after downstaging the tumor thrombosis with radiotherapy of two types. DARE, which is transarterial radioembolization, in which you put in yttrium-90 lipospheres in the liver through a transfemoral or a transradial approach through the artery. And SPRT, which is stereotactic body radiation therapy, or often given with cyberknife. So these two kinds of radiotherapy can be given to dissolve the tumor in the portal vein, and then these patients can have a transplant as long as they don't have metastasis. We showed it for the first time that such downstaging is possible. Now, this has now got introduced into the consensus guidelines of various world fora, including our own INISL guidelines. And what about the donors who have mismatched blood groups? I may need a transplant with blood group O. My wife may be blood group B. She wants to donate to me. Can she donate to me? Yes, it is possible. So now what happens is that if the mismatch is of A and B variety, which means I'm A, my donor is B, then we can do a swap transplant, which means there is another family with patient B and donor A. We can simply swap the donor livers, and that's allowed, that's legal, equally successful, no more costly, all good. But if there is a B to O incompatibility, then there can't be an exchange because nobody will give you a O. O is a universal donor, they'll donate for their own family member. So in that case, we do a ABO mismatch transplant, which simply means that if my blood group is O and my donor is B, my anti-B antibody levels will be measured, and if they are below like 1024, 1:1024, then I can have immunomodulation for 3-4 weeks with anti-CD20 antibody rituximab, which is basically going to kill the plasma cells, B cells, which are the antibody manufacturing cells, and plasmapheresis will be done, which will clear off the preformed antibodies, and then transplant will be done. So we were the first ones to do ABO incompatible transplants in India. Again, published this. We were also the first ones to publish laparoscopic donor hepatectomy from India. We teamed up with Palani Velu, who you may have heard of. Dr. Palani Velu is a very well-known laparoscopic surgeon. So those were the initial cases. Then we did some robotics, again, over 8 or 9 years ago. And then, of course, we have now, this is the same picture that Neeraj and I have in our presentations. The one on the left is the conventional cut, and the one on the right is the robotic approach, where you only actually see these holes. This is, of course, suprapubic and not normally seen. This is just put there for you to see where the incision is. We've now done a large number of robotic donor hepatectomies, and the benefits are pretty obvious. I won't run you through those. And in robotic surgery, we have described, again, for the first time, a novel CCC biliary technique which eases the bile duct management when doing these surgeries, and this is published. And again, a large number of robotic centers have adopted this technique. And outcome, Neeraj already took you through that. So this is pediatric, 94% 1 year, and long-term 87% survival. This is This lady is a donor for her father, then she married this man and they have a baby. This guy is a weightlifter. He donated for his father and after that he's continued competitive weightlifting. This is my favorite story. In 2006, we had a 14-year-old present to us with acute liver failure. She was in the emergency. I was in Gangaram Hospital at the time. And we went down, we saw her and she was hypotensive. She was in grade 4 coma. She had pneumonia. She carried a chest X-ray from outside which had pneumonia. She had AKI, renal failure. And the only way to save her was a transplant, but of course she was not fit for transplant, so we refused it. Her dad and mom were crying and the father walked up to me and said that, Doctor, अगर 1% भी chance है तो मैं अपना right side में अपना liver देना चाहूँगा और मेरी बच्ची को बचा लीजिए. I mean, patients do that, right? When you refuse surgery and when they have no other hope, sometimes you can't accept patients. But then, I don't know what came in my mind, and I kind of accepted that patient for transplant. And all the anesthetists and my team members were like very upset that kya ho gaya, Dr. Soin, but how can we do this case? Well, we went ahead, we transplanted her, and this is she after 15 years. She actually got married and they have a little child. And you know what? When I was in the car, she sent me this message. It is 18 years today. Neeraj, she was transplanted 18 years ago and she just sent me this message today. I just replied while I was reaching here. This is unknown cause. We don't know the cause of it.
Not happy.
This wasn't happy, no. It's a young girl, a 14-year-old.
Possible reason is a happy.
Happy is one reason, but this wasn't happy. Yeah. Anyway, so these are some of the other children we've transplanted, and many of the children have grown up. And like I told you, Neeraj showed you how they've become doctors, and so many of our children have become lawyers, doctors, dancers, sports persons, got married, have their own children. So these are beautiful stories. This is actually a part answer to what I was asked in the beginning. I mean, we do what we do because of this. That's why we do it. So we are pretty keen on academics and research all the last 20 years, 25 years. In fact, nobody knows this, but I moved from Apollo Hospital to Gangaram Hospital just to be able to do academics. Because at that time, in 2001, when I moved, Apollo Hospital didn't have any DNBs and academics, but Gangaram Hospital had a very strong culture of academics. So I took a 70% pay cut and I moved to Gangaram Hospital, which is where Neeraj and I met. Anyway, so we've trained like over 200 fellows, surgical fellowships. We have students in a lot of the centers of our country, like 90 odd centers, and we published 246 papers on liver transplantation in peer-reviewed journals, and also authored a book. So, liver transplantation obviously first firmly established in the country, both in adults and children, and 95% success, which means 95 out of 100 patients who get admitted will get discharged happy. And long-term survival among adults is about 75%, and among children is nearly 90% long-term survival. And we are talking 10 and 15-year survival figures. And of course, we have been in the forefront of living donor transplant in the world. And among the interesting innovations which help patients and improve access to transplantation are extended criteria of HCC, which I detailed, then ABO mismatch transplant, swap transplant, and of course now robotic donor hepatectomy is becoming pretty standard in experienced centers, and it increases the comfort and safety, but especially in liver transplantation. Thank you very much.
So, John sir.
So please come here. I think all of you would agree that we had a spellbounding presentation by Dr. Neeraj. We very rarely do we have presentations by people the stature of Dr. A S Soin and Dr. Neeraj, and we feel blessed and privileged to host you today. And we want to thank profusely the wonderful marketing team of Vedanta, led by Vanita Kwatwaji and Rahul Aneja, to bring these two wonderful gentlemen to us. Sir, you are not aware of our academic reach. Today is the 905th, 905वीं continuous uninterrupted CME over a journey of last 19 years of this forum. And I want to thank every one of you to be a part of that wonderful journey. And I wish to take it to at least 1000 before I give it to some of the young thugs of the forum. We are very grateful to you, sir, for the work that you are doing and for coming back from Cambridge to India. Sir, I would...
I'm grateful for bringing me back to my country.
Sir, I would start my questions, just 2 or 3 questions, but before that I would give it to Dr. Shubham, our moderator, to set the ball rolling. ये चल ही रहा है, ये चल ही रहा है.
आपकी आवाज कैसी
Sir, just a basic question for the physician, sir. What is the, like, if we refer a patient to you for liver transplant, what can we tell the patient, because cost is an issue with liver transplant? So what can we tell that if the best surgeon in the world is operating you for liver transplant at Vedanta, Dr. A S Soin and Dr. Neeraj team, what would be the cost? Is there a package or how the finances are saying?
See, the first transplant that I showed you that I did in 1998, the family was charged 18.5 lakhs. Okay. And today the package for adults in Vedanta is 20.65 lakhs. I don't think there's anything that has remained the same in 26 years in terms of price. But it's just that obviously a lot of people fall out of the ambit if you increase the price any further. There is about 1.75 lakhs that is spent on evaluation, so total expenditure is in the region of 22.5 to 23 lakhs for adults and about 3 lakhs less for children, so 19.5 lakhs for children. We have a high-risk package which is 3 lakhs higher than what I just said. Robotic surgery also costs 3 lakhs extra, and about 10 to 15% of the patients will pay up to 2 to 3 lakhs above all this because they are sick, they are more in ICU and so on. So I've given you the complete realistic picture. But majority of adults who are stable will probably pay less than 25 lakhs and have a transplant in any of the private institutions, not just in us.
The point is that with quality the price goes up, so I think there is a misconception with people. Like I work in gastroenterology and I had a feeling that in Vedanta it is expensive than maybe ILBS or maybe
ILBS, yes, we are about maybe 15% higher than ILBS, but not a lot.
Yeah. So I thought it's around 35-40. What I was telling my patients, because I really was
State government hospital.
so, yeah, so sir, while referring patients, like a lot of people here would want to refer you patients, knowledge about the cost is important, that's why I asked you this question. Second, sir, from a gastroenterology point of view, we talked about ABO mismatched transplants treated with rituximab for 3 to 4 weeks. So my point is that a lot of cirrhosis would be hepatitis B related. And if like for a gastroenterologist, if you are total anti-HBC positive and an HBV DNA negative, we ask no rituximab at any cost. So is that followed with you guys here, or because what we know is that it is pure bone marrow ablation with rituximab for 3 to 4 weeks. So there is a good chance of HBV reactivation like a lot of chance. And if you have total anti-HBV positive patient goes into chemotherapy also, then we have to like start tenofovir, alafenamide or tenofovir 4 weeks before chemotherapy and 12 weeks after chemotherapy. If that is what I'm talking about, AS70 2020, if I'm correct, so you can correct me.
You're absolutely right. What you asked is, it's a pretty rare situation. First of all, the transplant for hepatitis B have gone down drastically with these new drugs. And then ABOI in the hepatitis B even more uncommon. But all patients undergoing transplant for hepatitis B will be on antiviral. So if they're on antiviral, then you know they're very potent now. So, and a lot of times actually pre-transplant to decrease their antiviral, we put them on dual antiviral. So they would be on anticlotting and tenofovir. So with dual antiviral, you can safely give rituximab. There's no problem. They've never had a problem. I think the antiviral, the viral suppressing so well that it's never a problem.
This would be my last question. So when I was reading Schlesinger, so it was like Barcelona cancer liver clinic staging, and we were like that sorafenib in a metastatic disease and a tear or in a what do you call B stage where, yeah. So do you guys follow the BCLC still? And if I remember correctly, UCSF said that the size 1.5 centimeter was more than Milan. And if you have actually given up both Milan and UCSF with your new developments, because I have not read surgical papers which I saw today, and I'm sure I'll be reading them in future. So I was just amazed with the kind of data you guys have. It's amazing.
So everybody has given up Milan and UCSF for what they are, because they are just size and number criteria, everybody, including US. So now the acceptability criteria for allocation of livers for HCG patients in the US and all deceased donor systems always include AFP. And AFP is one of the biology determinants, right? And so there are, if you want details, there are AFP, PIVCA2 or DCP. And FDG avidity, that's FDG avidity is bad. Response to local therapy, good response is good. And if you have a waiting period and nothing happens, that's also good. Why am I telling you all this? These are all surrogate markers of good biology. So good biology, you can transplant even if there are 10 tumors and the highest one is 10 centimeters. That's been shown by several people now, not just us. Although we were the first ones to go all size, all number, but now it's being shown across the world. So people have moved to size, from size number to size number and tumor biology.
Neeraj sir, do you have any experience with nivolumab and transplant, like hepatitis B related HCC and PDL1 inhibitors? Because I don't have experience, I just have read about it, so I think you're a better person.
So nivolumab no one uses now, and it's actually withdrawn as a single agent. It's not approved anymore. The new drug, as we all know, is atezolizumab. And so till now, the concept was that you should not use atezolizumab prior to transplant because it causes rejection after transplant. But now, recently, in fact, there is a paper just about last week published from Dr. Vatsya, who has the maximum work from Sinai. And so you can use atezolizumab in these patients to downstage them, provided you give a cooling off period of at least 6 to 12 weeks. So you need to wait for 6 to 12 weeks, and then you can transplant them without any increase in rejection. I have transplanted 8 patients. This is the largest series in the country actually. With giving atezolizumab, downstaging them, and then doing a transplant. We have not had rejection in a single patient. So I think you just need to be more careful. You need to monitor them well. You know, I tell you the biggest problem. Why data is so different from the West and what we do. Atezolizumab is contraindicated after transplant. No one in the world uses it. We've used it in 3 patients. We've not had rejection. It's not that I'm a great doctor, that's why they've not had rejection. Because, you know, in the West, they have protocols. The person will come and he'll go away and he'll be asked to come back after 3 months. And in that 3 months, what happens, no one knows. Here, we have a personalized system.
patients can reach out to us, we reach. So, yeah, and it's such a close follow-up, and that is the reason that we can monitor them so well and we can, prevent these complications. So, Web, yes, we've used it in pre and post and without any problems.
I would request the insight and input and a word from our pediatric gastroenterologist, Dr. Saraf Gopalan, who incidentally keeps sending cases to Dr. A S Soin, sir. Your take, Dr. Saraf. You have the mic. The mic is there.
I just wanted to let you know. I've sent you 3 patients, if you remember, over about 20 years. One of them had hepatic artery with sepsis and sepsis, and also the problem was the patient came out of it and is still difficult. So I want to put this as a landmark piece for you, because 3 complications: sepsis, Klebsiella, and sepsis, and on top of it, Cmes and hepatic artery thrombosis. They came out. I referred the case to you way back. You were in Ganga, you were not in India. And you had 2 other straightforward cases after that. One in Ganga and one in Nana after that. But the first case was very clear. This was 2005.
All right.
I just want to remind you.
On that score, Saraf, can I ask you and Dr. Neeraj, what are the common indications of doing liver transplants in children? We would like to know that, because in adults the scenario is different.
Yes. EHP, very common complication.
What is
EHP?
What is
extrahepatic biliary atresia.
Okay.
If the bile duct is not formed,
All right.
then the problem will be that over a period of time, the liver will disappear.
So let me go to Dr. Soin, sir. Sir, do you do EHBA and what is the prognosis? Can we have some decorum, please? Just 10 minutes of question answers. I assure you, we will have another CME from Dr. Soin and Dr. Saraf in next year, 2025. Just keep decorum.
Yeah, so 1 in 15,000 children will have this condition called extrahepatic biliary atresia, in which the bile ductal system inside of the liver is not well formed. And of course, there are several types. In some, the intrahepatic thing is completely not formed, the other is partially formed, the third one, the extrahepatic system is not formed, the internal system is okay. So anyway, there are various types, but 60% of children less than 5 years will be transplanted for EHBA. But they usually present in the first 2 weeks with jaundice. And if they are operated upon with an operation called portoenterostomy or Kasai's operation, in the first 60 days of life, then about 30% of them respond very well for a few years, of which maybe only 10-15% will last a lifetime. The rest of them will have a transplant, and the 70 who do not respond well with any way to a transplant. So, frankly, a very small percentage of these cases can get away without a transplant. Eventually, they will need a transplant.
The biggest problem we face in pediatrics is late referrals. Most patients come to us at 2.5 or 3 months age. It's too late at that time for a liver transplant. For Kasai operation. Dr. Arvind knows it. At that stage, the results are disputed. So, at that stage, after 2 or 3 months, invariably, the liver enzymes will rise and only a transplant.
Sir, what is the earliest pediatric transplant we have done? Age?
The other indication is hepatitis A.
That's an answer. I asked him a question. Sir, please. Earliest age?
2 months, 2 kgs.
Wow. Who donated the liver?
Father.
How much liver you took out, sir?
Monosegment. Monosegment means one segment. There are 8 segments in the liver. So we did a monosegment transplant. And that was also reduced. So actually only half a segment. Here there's a 2.1 kilo baby.
Can we call you a magician, sir?
Oh no.
I would request Dr. Amish Vora to ask a question.
Thank you so much. I am a medical oncologist. So, what Shubham you asked, I would like to share my experience and one question to Dr. Soin. I have had 3 patients post-transplant on Etoposide. 2 in fact relapsed after the transplant in your institute. I had all 3 died because of transplant rejection. Probably I didn't do as well as you people did, but I just wanted to share, sometimes because you get these rejections and 2 of them rejected very fast. Although there was, I applied, Korean was the first people who started doing this immunotherapy in post-transplant, then the China followed, then India followed. So I did that. So that was my experience. So I share away because it is still not a category 1 or category 2A recommendation to give that. So that is what I wanted to share. Dr. Soin, I wanted to ask you a question. It is absolutely wonderful and I bow down to you because macrovascular involvement in HCC, we had nothing. The patient, no matter what you give, will not survive beyond 2 years, maximum 1.5 to 2 years. But difference between SBRT and TACE versus TARE, and what are the criteria? Should the thrombus be completely dissolved before you take for LDLT? What are the criteria and what is your success rate in this macrovascular involvement?
Very, very relevant question. So TACE, ladies and gentlemen, is transarterial chemoembolization, which means that one segment or a sector or a lower artery is actually embolized. And there is Lipiodol, which is mixed with doxorubicin, and that is injected into the tumor. So that is not done for patients with significant portal vein thrombosis. Because then you're going to block off the artery, the portal vein is already blocked. So that part of the liver is going to necrose. So TACE you will never do for traditional PVTT cases.
TACE with SBRT, there are a lot of case reports.
No.
Hepatic
So what happens is that if there is portal vein tumor thrombosis, that normally is contiguous with the main mass. So if there is a right-sided mass, usually there will be a right-sided thrombosis. If you want to do TACE, that will be also into the right artery. So this is a bad combination. But sometimes what happens is you are able to get to segmental arteries. In that case, yes, TACE has been done for downstaging, but we don't prefer TACE for downstaging, we prefer TARE. Because in TARE, you do not actually occlude the artery. You just use the arterial access to reach the tumor and deposit your uterine hypospheres into the tumor. So there is a little difference between TARE and TACE in that respect.
Dr. Soin sir, Dr. Amish Vora is running his own oncology center in Hoskas, home
Yes,
oncology.
we know that.
He is a DM in oncology and worked in Tata and other places. He is a wonderful oncologist, and as wonderful as you are on hepatic transplant, sir, he is our go-to oncologist, sir.
Yes, I just wanted to know, once you downstage, what is your success rate? 1 year, 3 year and 5 years. Not overall though I saw.
So we have published this. In fact, we published about 3 papers on this. What happens is that the 5-year survival rate in our patients, now in cancer, you look at overall survival and you also look at recurrence-free survival. So overall survival is 62% at 5 years. Okay? And we have never had a recurrence in anyone in this protocol after 5 years. All the recurrences have been between 2 and 3 years, right? And in terms of recurrence-free survival, if you discount the early deaths, then it's been 67%, basically, right? And these are published figures, and we have now close to 18 patients who are beyond 5 years. And about 30 odd patients who are beyond 3 years on this protocol. So obviously, and if you look at the survival figure, you have those numbers given according to years, right? So we have that.
So some common questions. You said right now we accept with 20% fat and left with 30%. So left log is a smaller log, and there you accept with 30% fat. Means liver tissue will be still less.
So the donor loses the left lobe, and that's a smaller lobe, and that is okay with 30%. I don't want to leave the donor with the left lobe when he's donating the right lobe with 30%. You understand?
So it's basically donor's perspective.
So donor's perspective, donor will keep 65% of the 30% wala and 35% of the 20%.
Yes. My last question, in AB or AB mismatch, you prefer swab donor. But when there is O and B, then you prefer, you can do mismatch what you do.
AB1 compatible transplant.
So what is the success rate in that mismatch?
It's about 5% less. So we have discharged, I think, like 88-89% of our patients as opposed to the 95%.
Sir, Dr. Rajni Chakravarti has a question.
Nice talk, sir. I just want to ask something. We have so many criteria for live donors. What are there any criteria for cadaveric donors? Do we have any brain dead donor? Anybody can donate, or we have some criteria for that too?
Yes, so cadaveric donors, okay. Anyone from literally 2 months of age or even less. I think the youngest donor in India has been 2.5 months. But anyone from any age to even 100 years of age can be a cadaveric donor. Now, cadaveric donors are basically, in the sense that we are talking about, where they donate organs for transplantation, they have to be brain dead donors. Brain death, as you know, as a doctor, happens to 1% of us when we die. 99% of us die from a cardiac death, 1% die from brain death. These 1% of the people are potential brain dead organ donors. They happen in neuro ICUs, and they have had either strokes or they've had a road traffic accident with head trauma. And then these are the 2 common causes. Of course, they can be drowning and hypoxic brain death. So then there are brain death declaration criteria, or brainstem death declaration criteria that have to be identified by the ICU guys and the treating physician, signed by 4 doctors. Once they're declared on 2 occasions, 6 hours apart. So once that is done, the first set, after the first set, the family is asked permission, like your loved one unfortunately is brain dead. I mean, of course, it's a long process of treatment. And if you wish to donate organs, then this is a good time to think about them, then there comes the word organ donation. These patients should not have metastatic cancer or even non-metastatic cancer, because they could have hidden metastases in liver, kidney and all that. So cancer patients are out of the brain dead category, or brain dead donor category. Gliomas, glioblastomas are a no-no, but meningiomas are okay. Then they should not have serious disease of the organ that they are donating. If they have extensive lung fibrosis, they can't become donors. If they are 75 years old with coronary artery disease, they can't be heart donors. Or if they have liver cirrhosis because of whatever, they can't be liver donors. But they can still donate kidneys. They can still donate other organs.
So for liver, we generally have, if they have any cancers, if they have any hepatic, serious hepatic disease like cirrhosis, so those are the patients that are excluded. Others can more or less donate.
Then rarely florid active infections are also excluded. But usually what happens is you treat them for 48 hours with the susceptible antibiotics, and 80% of these can become donors.
Because it's a very emotional thing. If the relatives agree to it and then they come to know that no, their person, they have taken out the liver but it cannot be donated.
Yeah.
So that's why I wanted to ask what are the criteria.
Very relevant. Yeah.
Thank you.
Dr. Saraf, just keep your question, just for a second. I would go to Dr. Tulsi sir and ask him to ask 3 questions quickly.
3 questions?
Yes, quickly.
And that too very quickly. So, Dr. Neeraj and Dr. Arvinder, what a wonderful talk we had today. Probably one of the best talks we've heard on liver transplant. My best friend, Dr. Vijay Bora, is your pillar of strength at Medanta.
Has been for 23 years, since 2001.
And his wife, Ritu, has been my colleague at Moolchand Hospital. Let me proceed, sir. So, Dr. Arvinder, 26 years of liver transplant with Dr. Arvinder Soin, AIMS to Cambridge, to Gangaram, to Apollo, to Medanta. What has changed, sir? Are the outcomes similar, short-term outcomes versus the improving the long-term outcomes after liver transplant? Tell us about this, sir. What has changed?
So the first and the second cases I did in Apollo worked. The third one did not survive. Then the fourth and fifth again worked. Then we lost 3 patients.
What has changed, sir?
I'm telling you the story as it happened. So I left Apollo Hospital when I had done 23 transplants with 60% survival. 60%. Then in Gangaram Hospital, first 2 years we didn't do that well. Actually, we didn't do anything for 3 years. 2004 we did the first transplant in Gangaram Hospital. And then first 2-3 cases didn't work, and Dr. Sareen and came for inspection, and we had a difficult time to justify to him why we should continue the program. I'm telling you, everything is not rosy, right? It's difficult. When I had switched from Apollo Hospital to Gangaram Hospital, Dr. Sama told me, why don't you come and start the program here? I know you've done liver transplants in Apollo. You know what I told him? I was young and I was quite carefree, and I said, Dr. Sama, I've heard your hospital is really old and the OTs are really bad. I won't be able to do liver transplants. He's like, no, by the time you come, in the next 3-4 months, the new building will be up and running. So I believed him, I said, okay. So then I joined. And after 15 days of joining in 2001, I asked my friend Dinesh Kullar, I said, Dinesh, ये नई building कहाँ है? So he took me to a great big hole in the earth, and he said, यहाँ बनेगी नई building. उसके बाद it took 4 years for the new building to come up. Anyway, so in the beginning, the success was low, but by 2006-07 we had reached 90%. And since then we have been consistently in the
90% at 1 year.
90% people discharged,
okay,
and about 3-4% do not make it the year, the rest of them do, right? And this figure has slowly risen to 95, 96, 95, 96. But now the main focus is on long-term survival. So which is what Neeraj actually took you through in his talk. So now the focus is, how can we get these guys to do 10 years, 20 years, even longer, children, their entire life. That is the focus.
As we know today, less than 50% of the people survive beyond 20 years. What do you say, Dr. Neeraj?
I didn't get the question.
Less than 50% of the people survive more than 20 years.
Beyond 20 years.
Transplant.
Post-transplant.
No, I couldn't agree with that.
No? How much is the survival rate after 20 years?
I think about 70%.
70%? Wonderful, sir. So, Dr. Soin, shifting etiologies of cirrhosis, more patients of ALD and NFLD than HPV and SCV infections, and they are now treatable or are probably partially curable as well. So, more patients, shifting etiologies to ALD and NFLD.
So we actually wrote a paper on this in the Journal of the etiologies have shifted. In 2015, 25% of our patients were hepatitis C. In 2024,
0% of our patients are hepatitis C. Hepatitis B has gone down drastically, 12%. And now what we have are only basically majority two diseases, alcohol and non-alcohol. These comprise 90% of our transplants.
My second question would be regarding obesity, which has become, the most common chronic health condition in the world, and the impact on liver disease has been dramatic. So, obesity, a big problem causing NFLD or NASH. So, after LT, a liver transplant, if you have obesity, you need to treat them for better outcomes. We need to have drugs like, either a bariatric sleeve gastrectomy or a GLP-1 agonist or incretin-based therapies. So talk us about the obesity after liver transplant.
So yes, like I told in my talk, obesity is a major problem of transplant because these are all patients who couldn't eat, not allowed to eat. So when they are well, they eat and they overeat and they become obese. So obviously I think the mainstay of managing obesity has to be lifestyle, diet and exercise. But yes, we are using semaglutide now. And in fact, we are, we have a large experience of semaglutide post-transplant. And I think it works in about 1/3 of the patients. It doesn't work in all of them. We have done bariatric surgeries and sleeve gastrectomy is the best option for these patients post-transplant. But I think we have probably a handful of patients who have undergone bariatric surgery.
My last three questions would be regarding LT from donors who have HPV, HCV, HIV, SARS-CoV-2. Now become, this is expanded. The donor list is expanded to include these. What do you say, sir?
So in living donor, hepatitis B we will never take. Hepatitis C we have never taken, but theoretically we can take because it's a curable disease. If they have been cured of hepatitis C, I would like to do a liver biopsy, make sure that the liver is normal. If it's normal, then I can take HIV, again, absolutely no.
I thought these have expanded now, the indications are expanded to include
No, sir,
these.
because we are worried about the donor safety. So hepatitis B donor, I don't want to leave him with 30% liver because I don't know how it will regenerate or not.
Okay, talk us about the retransplantation. At least 10% of the people, patients you properly transplant would need a retransplant. What do you say, sir? Retransplant.
So 10% is very high. I don't think 10% needed, but yes.
I'm quoting worldwide statistics.
So retransplant is not easy. It's technically difficult, and the biggest problem with retransplant is that patients, who need a retransplant, half the time would not have finances, would not have another donor. So retransplant is not easy. We have done, I think, at least, Dr. Soin, how many retransplants have we done?
25.
25 or so, yeah.
35.
35 is worldwide figure is 10%.
No, 35 out of 4,000.
Retransplantation worldwide.
35 out of 4,000.
4,000, whatever. Yeah.
So that's 10%. Okay,
No, but-
talk us about the SLT.
That's 1%.
Worldwide figure.
Worldwide are, new figures are about 7-8. For DDLT.
Okay, talk us about the SLT, Neeraj. SLT. SLT, sir. Split liver transplant.
Split liver.
Pediatric and adult.
So split liver is mostly possible in a cadaver situation. And unfortunately, we hardly do any cadaver.
Thank you, sir.
So,
Dr. Swain sir, just एक राम करना चाह रहा हूँ आपसे एक लास्ट सवाल था